Hi, today we're going to talk about how to position an implant, a single implant in a single space without a guide. Obviously, the guide will facilitate a lot of this, but for the sake of the argument, we have a case without a guide. Let's just talk first about what causes positional problems when you're placing an implant in a single bounded space like this. First of all, there are three reasons. One of them is the wrist twist. And the wrist twist, meaning that you're holding your handpiece with the drill, okay? And then you're trying to drill the osteotomy hole, right? But instead of going straight like this, you're using the handpiece as if you're using it to drill a cavity or a crown prep. So your wrist twists, okay? So when your wrist is twisting, right, there will be the trajectory of the apex of the drill will go medially or distally. It depends where you're coming from, okay? So first is the wrist twist. How to get over that? First of all, you have to hold the handpiece and support your hand with two hands, okay? So don't put your hand or your finger rest on one of the teeth while you're trying to drill, because then your wrist will twist, right? So up and down in a straight line, okay? So that's the first problem that causes the trajectory of the implant placement to veer off the ideal straight path. The second is variable bone density. So when you finished your osteotomy, right, and you've done everything to make it parallel and you're placing the implant, if the bone density is variable as you go from coronal to apical, the apex of the implant will start to follow the line of least resistance. So the line of least resistance means that it will hit the softer bone and it will go with it. So as you're driving the implant down, the implant will start to tilt. And that means that there's variable bone density in the cancellous bone rather than a uniform density. So that's another problem. Now, to do that, you have to notice how the implant is going and make sure that you direct it to the straight path, right? When you feel that the implant is veering towards the line of least resistance, just to try to upright it so that it goes down straight, okay? The third and most important is the axis. Remember that you've got a handpiece with a drill and you have to put it in the patient's mouth and you have to go towards the center point, okay? So all that requires good access. If you haven't got good access, then you either use shorter drills, shorter implants, or you will be trying to do something extremely difficult. There are some guides with a side slot where the drill can go from the side. However, you still have to go through the cheek area and then direct the drill towards the osteotomy and then use the guide to direct the drill down. Again, the axis will direct sometimes the apex of the drill because the patient's mouth has a certain opening. And while you're putting the handpiece in, the upper molars will hit the body of the handpiece, and that may make your trajectory veer from the ideal. So you have to, while you're doing your diagnosis, you have to realize what this axis will accommodate, whether it is going to accommodate the handpiece and the drills, or is it not, and you're going to suffer and the patient is going to suffer. Or you're going to end up with a far from ideal placement. Okay, so these are the problems that can cause positional problems with the implant placement. Now, the other is trying to figure out where the implant center point is going to go. And as a rule, you need 1.5 millimeter minimum between the implant periphery okay, and the adjacent tooth bone, okay. So if you have enough bone, which is about 1.5 millimeters, okay, and there's 1.5 millimeter here, so i.e. it's 3 millimeters, right, in addition to the diameter of the implant itself, then you're safe, okay. So then you can actually place the implant there. For example, let's assume that you're going to put a 4 millimeter implant here, so the 4 millimeter plus 3 millimeter is 7 millimeter minimum. More is better, but minimum of 7 millimeters. If you haven't got the 7 millimeters, then a smaller implant. If the smallest implant you have is 3 millimeters, for example, and you haven't got a space of 6 millimeters, then other options have to be considered. Now, how to work out the center point of the implant? The center point is actually in the center of the implant. So if you're measuring the space to the center point, you have to add the 1.5 millimeter plus the radius of the implant. So the radius means if the implant is 4 millimeters, so from here to there has to be at least 3.5 millimeters, okay? And from here to there, to the center point, 3.5 millimeters. And that is your center point, okay? So you have to center the implant 3.5 millimeters from here and 3.5 millimeter from there, okay? So you have to have the center point of the implant 3.5 millimeter here and there, 3.5 and 3.5. And that's the center point. And then the osteotomy will enlarge as you enlarge your osteotomy with your drill. Obviously, the buccolingual width has to be adequate. We have to, as a rule, to have 1.5 to 2 millimeter better, 2 millimeter of buccal bone, okay, and palatal covering the implant, okay. So you have to have this. So you've got to figure out how much width of bone you have from your CBCT or from your ridge mapping. I think ridge mapping is quite historical, so now it's measuring it from the CBCT. Okay, the mesodistal we've talked about, so you have to have the implant diameter, right, plus 3 millimeters minimum, and that has to equal the bone width between the teeth. And if that's less, then you have to choose a smaller implant or abandon the whole thing if you haven't got a small diameter implant, okay? Or your implant system doesn't cater for small diameter implants. Remember that the smallest diameter implant that we can use, there are some 3 millimeter implants. I don't use them, but the 3.5 millimeter implants and above. Obviously, the coronoapical is the bone height. So you have to have enough bone height and you can measure the length from there. So just to sum up the rules, you have to have 1.5 millimeter of bone width between the periphery of the implant and the adjacent teeth. Buccolingually, again, 2 millimeters. Buccally, buccal bone is very, very important. And lingually or palatally. The palate is not a problem because the palatal bone is quite thick by nature. But buccally, you have to have that at 2 millimeters. Sometimes, if the palatal vault is very high, you're very, very limited with space. So you've got to really measure accurately how much bone you have buccally and lingually from the implant circumference or periphery. Now, another thing is that you have to place the implant about 3 millimeters below the gingival margin. Now, I would do that, plus I would place the implant about 1 millimeter subcrestal as well, because we know that the crestal bone will remodel over time and we will lose some bone. So if we place it 1 millimeter to 1.5 millimeter subcrestal, then that bone, when it's lost over time, we are still safe. Okay, so summing up, positional problems is caused by the wrist twist, okay, the variable bone density at the time of insertion of the implant, and the access problems. Okay, positioning of the implant, buccolingually and lingually, you have to have 2 millimeters of bone buccally and 2 millimeters palatally, 1.5 is acceptable, but I would say 2 millimeters as well, right? Between the implant and the adjacent teeth, there should be at least 1.5 millimeters between the implant periphery or the implant circumference and the teeth on either side. Coronoapically, you've measured the bone height, okay? And that's it. So if you maintain, if you look at these rules and maintain these rules and protocols as you're placing a single implant in a bounded space, you will avoid positional problems. Thank you.